everyone. Today we will discuss about varicocele, their causes, their pathophysiology, diagnostic features, and indications of treatment. So, what is a varicocele? A varicocele is a group of dilated veins in the pampiniform venous plexus. These are abnormally dilated and tortuous veins of pampiniform venous plexus within the scrotum caused by venous reflux. They occurs approximately in 15 to 20% of the general male population and seen in 35 to 40% of the men with primary infertility, seen in up to 80% of men with secondary infertility, and they are more common on the left side. Anatomical relevance to the varicocele. Pampiniform plexus drains testicular blood. Left testicular vein drains into the left renal vein, which is longer and forms an acute angle. And right testicular vein drains directly into the inferior vena cava. So you can see here one side image, right side image shows healthy testicle along with its structures and blood supply, and you can see on the left side testicle with a varicocele where you can see the dilated veins. And this picture is also showing varicocele on the left side, and here you can see left testicular vein drains into left renal vein, which then drains into the inferior vena cava, and right testicular vein drains directly into the inferior vena cava. Etiology and pathophysiology of varicocele. It includes following factors: incompetent or absent venous valves, increased venous pressure, venous reflux, and pooling of blood, which will lead to increased scrotal temperature, testicular hypoxia, oxidative stress, and impaired spermatogenesis. And this picture is also showing the various causes of varicoceles and their pathophysiologic mechanisms. Like you can see the endocrine factors, testicular hypoxia, and scrotal hyperthermia, reflux of adrenal metabolites, and cadmium accumulation. All these factors leading to impaired spermatogenesis and elevated reactive oxygen derived species, which will ultimately lead to impaired sperm function, causing decreased male's reproductive potential. Classification of varicocele. Clinical grading by Dubin and Emilar shows four grades of varicocele. Grade 0 is subclinical, which is detected on imaging only, like on Doppler ultrasound. Grade 1 varicoceles are palpable only with Valsalva maneuver. Grade 2 varicoceles are palpable at rest, and grade 3 are visible and palpable varicoceles. And on physical examination, examine the scrotum with the patient in supine and upright positions, and while he performs a Valsalva maneuver in the standing position. A varicocele feels like a bag of worms and should become more prominent when the patient is standing or performing a Valsalva maneuver. And then we will determine the varicocele grades. Clinical features: often asymptomatic, dull etching, scrotal pain, feeling of heaviness in scrotum, visible or palpable bag of worms, and testicular atrophy can result, especially in adolescent patients. What is the impact on fertility? It can cause Oates syndrome, which is oligoasthenoteratospermia, causing decreased sperm concentration, reduced sperm motility, increased abnormal sperm forms, and DNA fragmentation of the sperms. The most common finding is although decreased motility. Examination. Clinical diagnosis is on clinical examination in standing position, inspection and palpation of the scrotum, Valsalva maneuver to accentuate the veins. Diagnosis. Scrotal Doppler ultrasound is diagnostic, which shows dilated veins of more than 3 millimeter, venous reflux on Valsalva maneuver, semen analysis according to the WHO criteria, showing the affected semen parameters. What are the indications for considering varicocele repair? These include symptomatic varicocele like painful Presence of all of the following criteria like palpable varicocele, abnormal semen analysis, male infertility, and the female partner has normal fertility are a correctable cause of infertility. Repair of a subclinical non-palpable varicocele is not recommended for the treatment of fertility. Adolescents with a varicocele and ipsilateral small testes, repairing a varicocele in adolescents has been shown to reverse testes atrophy, but it does not seem to prevent fertility problems. So, for varicocele repair versus assisted reproduction, we can discuss this thing about later on in upcoming lectures. What are the treatment options available for varicocele repair? These include following surgical approaches like open surgery through inguinal, subinguinal, or retroperitoneal high ligation, laparoscopic surgery, ligation of retroperitoneal spermatic vein, and thirdly, percutaneous radiologic embolization. So, first of all, high ligation procedures and gold standard for varicocele repair is low ligation, microsurgical subinguinal varicocelectomy, which is ligation of the veins at the lower level. Second one is high ligation procedures above the inguinal canal. It includes Palomos procedure, which is high retroperitoneal ligation. Here, testicular vein is ligated with or without testicular artery. Traditionally includes artery ligation. Second is modified Paloma procedure. It is also high ligation, preserving testicular artery, reduces risk of testicular atrophy. And third one is at the inguinal level, which is intermediate ligation, include I1 Isivich procedure. It includes ligation of varicocele at the inguinal canal. Testicular vein is ligated while preserving the testicular artery. Next treatment option is laparoscopic high ligation, include laparoscopic varicocelectomy equivalent to high ligation. It can be artery sparing, non-artery sparing like Paloma type. And last option is radiographic percutaneous embolization. So this picture is showing all three approaches: subinguinal low ligation, then inguinal ligation, then retroperitoneal ligation. So what are the recurrence rate for different approaches, treatment approaches of the varicocele? A retroperitoneal approach can cause 15% recurrence rate and 8% risk of hydrocele formation. Inguinal approach can result in 3% recurrence rate and 7.3% hydrocele risk. Laparoscopic ligation can result in 4% of the recurrence rate and 2.8% hydrocele. Radiographic embolization 13% of the recurrence rate and 0% hydrocele formation. Microsurgical ligation has least recurrence risk, that is only 1%, and hydrocele risk is also very less, 0.4%. So standard procedure for varicocele repair is microsurgical subinguinal varicocelectomy. So complications of the treatment. Most common complication is hematoma for the microsurgical approaches and hydrocele formation for the retroperitoneal, inguinal, and laparoscopic approaches. Hydrocele is rare after embolization. Other side effects include scrotal edema, recurrent varicocele, testicular atrophy, testicular artery injury, and infections. So, what is the efficacy? Varicocele repair improves semen quality in approximately 70% of the male by 3 to 6 months and increases pregnancy rate by about 20%. Varicocele related pain resolves in 48 to 90% of men after varicocelectomy. So, after varicocele repair in infertile men, perform semen analysis every 3 months until either 1 year has passed or pregnancy occurs. So, summary of our today's lecture is that varicocele is a common and treatable cause of male infertility. Left-sided predominance is due to anatomical factors. Diagnosis is primarily clinical. Microsurgical repair offers best outcomes like 1% recurrence risk with microscopic subinguinal varicocelectomy, and varicocelectomy improves semen parameters in 70% cases and increases pregnancy rate in about 20% of the cases. So that's all from our today's lecture. Hope to see you in upcoming lectures. Take care till that time. Wish you all best of luck.